Hello, everyone. Welcome to a conversation about the need to modernize funding for community behavioral health in Washington. I'm Annie Alley, and I'll be moderating this session with our panelists. These are the CEOs of three of the largest community behavioral health providers in our state. Over the next 20 minutes, these leaders are going to answer our questions and share their firsthand experiences about providing care. If you have questions, please use the Q&A button on your screen, and we'll cover as many as possible. And with that, I'd love to introduce Jody Daly, CEO of Comprehensive Healthcare in Central Washington, Tom Sebastian, CEO of Compass Health, which serves Northwest Washington, and Jeff Thomas of Frontier Behavioral Health in Spokane. You might have seen him speak a little bit earlier today. Together, these panelists, plus Patrick Evans of Sound in King County, have formed Fourfront Contributor, which is a behavioral health leadership and advocacy coalition. Thanks everybody for being here. And before we get into our questions, I was hoping, Tom, that you might tell us a little bit more about Fourfront Contributor. It's relatively new, and love to hear a little bit more about the mission.
Yeah, thanks, Annie, and hello, everybody. We formed Fourfront Contributor to really join together our collective size, our expertise as longstanding community behavioral health providers here in the state of Washington, and some of our thought leadership capacity in order to really advance really good, sound policy to support the community behavioral health system, as well as advancing best and evidence-based practices. So we've really come together with the ultimate goal of moving forward transformation in a positive sense for the behavioral health system here in the state. You know, today we're going to be talking about a really critical issue, probably the most critical issue that we are facing as providers in the behavioral health system here in Washington State, and that is our workforce shortage. So our ability to really be that safety net for our most vulnerable community members is at risk and in crisis. And so we want to share some information today about what exactly is going on, what the impacts are, and some thoughts about potential solutions to solve this crisis.
Awesome. Jeff, can you tell us a little bit more about this crisis and kind of, Tom mentioned a workforce shortage. What are you seeing across the system in terms of a lack of qualified staff members?
Yeah, thank you, Annie, and hello to everybody. I think the title of the presentation that I gave on behalf of Fourfront as a panel member earlier today, we use the term crisis, and we do not use that lightly. It is absolutely at a crisis level, and Washington Council for Behavioral Health, which we're all members of, put out a survey to all its members in March, and then put out a subsequent one just this past month. And not surprisingly to any of us, the data related to turnover rates and vacancies has gotten even appreciably worse just in the last 4 or 5 months. And some of the data points that are noteworthy: nearly a 30% turnover rate each year across all positions, 1 in 3, 18% vacancy rate for all staff, more than a 25% vacancy rate for master's level clinicians. It is extremely difficult and really impossible to continue to run programs and run them effectively and provide the quality of care we need to, and the capacity that's to meet the demand with that level of vacancy rate and that high of turnover. Just across our 4 organizations that constitute Fourfront, we have nearly 400 vacancies at any given time. It's led to challenges with us continuing to keep our programs open. Some have closed. In other cases, we've significantly curtailed access. In talking to other organizations across the state, just as recently as yesterday, Jody and Tom and I were in an email exchange with a colleague looking at closing an inpatient facility because they cannot find nurses to staff it. So it is at a crisis level.
Frightening. Jody, for you in Central Washington, how has it affected your ability to provide care?
Sure. Thanks, Annie, and welcome everybody, and good afternoon. I think the critical component here is the community behavioral health specifically is always suffered to some degree from a workforce shortage, particularly around providers, psychiatric care, and we all know those statistics, frankly, as well as licensed behavioral health professionals. That has always been a concern. But what's interesting now with the workforce shortage and the Delta variant overlay, and coupled with, I think, funding challenges, is now we're seeing kind of what I consider the guts of the organization being affected as well. Mm-hmm. And so people that I used to be able to hire and deploy in the community to really enhance my safety net, people like school therapists who do outstanding prevention work and link people to our services, right, to intervene in a quicker manner. To give you an idea, I've had 2 positions open literally for 2 years. And what's interesting to me is both of these positions, these school-based positions, are also had the ability to fund them through a SAMHSA grant, which allowed me to actually to increase their salaries. So number one, I have about 120 open position that is a challenge, but now it's getting interesting when we actually may have some possible funding to incentivize people to come into our systems. That's not working really well either. So it is very critical. I have a director position as well. So it's not just the licensed on the ground people doing interface that's been open for 10 months. I'm concerned people are not coming into our system. And I'm sure some of that is because, because of the competitive salaries, and it's hard, challenging work. And I think in Jeff's discussion earlier, Representative Den said it nicely, and Jeff, you might have to remind me, but he said something about the challenges don't, really assist with the risk. People are looking to really live healthy lives. And that means better salaries.
And on that front, just to be clear, and as reflected in the recently completed Washington State Council survey, the vast majority of individuals who are departing our organizations are departing for one reason principally. It is significantly higher salaries. Oftentimes 30, 35, size 40% higher salaries to work in other sectors, and those might be hospital systems. Those could be the federally qualified health clinics who are serving the same safety net population. Some of those state-funded programs. So it just leaves us, there's already not enough qualified workers, and we are just completely unable to compete for the folks that are in.
One important data set that I'd like to share that we've been looking at is our mental health workers, those vital employees who work our residential and inpatient units, so clients don't leave our community and don't go into higher levels of care and or create cost in emergency rooms. I was looking at the data of turnover, and last year my turnover was like 19.8%. Today it's 51%. These are the individuals who go to Lowe's or Walmart or Kentucky Fried Chicken or where else and do a shift, right? Our work is very challenging. You often take it home. You definitely think about it. So we see people walking away for positions that they, feel a little bit more healthy in.
Yeah. Well, and I'm curious, Tom, for you in Northwest Washington too, are you seeing this kind of from the client perspective? How is this, affecting, I guess, their access to care?
Yeah, for the first time in my almost 35 years, we've had to limit or in some cases not accept new referrals for our general outpatient services. So this really has dramatic impact. One, when people are ready for care, they're ready for care. And we have to be able to step into that moment and provide them very easy, quick access to care. And to not be able to do that is very frustrating for us organization-wide. But the other thing is, when we can't provide that basic level of outpatient therapy, oftentimes those issues for kids and youth and adults and older adults, they escalate. And then their needs become more crisis-oriented. The interventions that then really are appropriate to intervene at those junctures are, just more complicated. And so by not being able to intervene early, you really create chaos for those individuals and those families. And that's what's so disheartening about what's happening. It's just nothing we've ever experienced before.
Well, it's serious. So Jeff, you mentioned kind of state funding or competition across publicly funded healthcare resources. Along that lines, and we know the state recently made some investments in mental health, it has for several years, but this last legislative session, is that helping to solve the issue? Is the solution around rolling out new programs? Does that help address this?
Yeah, I think, the good news is that there are many wonderful concepts of programs that are much needed in our communities across the state, and funding is being allocated toward developing those programs. But the bad news, which far outweighs the good news, is when you do not have an adequate workforce, when you do not have the ability to pay competitive salaries, then adding still more programs to provide still more services, they are not going to be able to be staffed adequately, and B, it's going to create much more competition for that already limited workforce. It's going to further worsen the problem that we have. So it's really, unfortunately, despite what I know is good intent, it actually is having an adverse effect, and further stabilizing effect on community behavioral health systems and organizations.
Okay. Jody or Tom, would you like to add anything to that?
Well, I think Jeff stated it very well in the panel he was on earlier. There's all these good things happening that are adding to the challenge that we're facing, and it's just making it very difficult to maneuver through. So, on the face value, new programs, launching, expansion of current programs is all great, but our talent pool has dried up, and so all that causes is this competition between us to get this very limited number of qualified staff persons in order to really staff up and make these programs work. And I think our challenge as community behavioral health centers is some of that great work is happening with the federally qualified health centers, with the hospitals, with the state directly. And this is not, and again, I think Jeff spoke this very eloquently earlier, you're not talking about a 5 or 10% difference in compensation. You're talking about 20, 30, or more percent differential. And who can blame anyone for doing that, right? So, it's especially in this, environment that we're in for the last week.
I think a really good example of an unintentional consequence as well, outside of, the legislative session allowing new funding to come in for new programs, and we don't have capacity. The other unintentional consequence is the ARPA funds. So the American Recovery Act funds is being doled out, right, to the state, to county, to local influencers. And so what we're finding, which is really fascinating and creating some competitiveness internally in our organizations, is they're coming back to us and saying, hey, we want to hire a school therapist or a therapist in the jail, and they want to hire those individuals through their ARPA funds because they have 3 years at almost a 40% increase to the salaries that we can currently continue to pay this same therapist. And so we're having to make these decisions of, do we allow that to happen in our system? Because if we don't take on those contracts, they'll probably find someone who will. And we want to keep linked, right? It's really important for us, particularly as for the largest, I think, community-based mental health centers, to have an adequate continuum of care. That actually drives down our cost if we have a really good continuum of care. So you don't want to lose a whole bunch of pieces, and you don't want to become fragmented. But I'm also seeing that interesting, competitiveness coming from the ARPA funds as well.
Yeah, that's an interesting dynamic. So here we have a great question from Dan, and I think I'll specific to his question, but I think that starting to talk about solutions. So thinking about what solutions might be out there and what framework we need to help drive that. But Dan asked, our pilot programs, that are trying new models of pilot programs are trying new models of supporting organizational investment in clinical training. For example, incentivizing or reimbursing supervisor time. Is that helping, and do those that train with you stick around?
Can I add a comment to that? Because I know Tom and Jeff certainly will want to talk about some of the solutions for the future. But one of the things that I can tell you from a comprehensive healthcare perspective is we carve out close to $100,000 a year to incentivize and support people in our system to get higher degrees or healthcare degrees that are important or key positions. And I was just looking at our data. We sent 18 people to school last year at about $97,000. So when I go back and I look through the years, that model is who I'm keeping. There is definitely about an 85% longevity rate if we mine our own people and support them. So I'm a huge advocate, and I know things are coming down the pike that both Jeff and Tom can speak to that we're really hopeful for, and some solutions that we're suggesting. But there is no doubt in my mind, if we can access investments that allow the people who are currently in our system and people that are interested in our industry come into it and be supported financially, we're going to keep them. I'm seeing that now at a smaller scale.
Yeah. That's interesting. So Jeff and Tom, we'd love to hear your thoughts on how we could potentially scale those incentives, and or what are the kind of criteria or framework that we need to help really address this issue.
Well, jumping off on Dan's question, and then maybe going down the trail of incentivizing, I think that yes, the answer to Dan's question is yes. I think supporting individuals in providing clinical supervision, that is helpful. But I think that and a variety of the other kinds of initiatives that are underway, all of which are good, whether it's making it easier for licensing reciprocity, easing the pathways for people to get their SCDP. Those are all really good things. Unfortunately, they are, even in combination, just woefully inadequate. And that's not to disparage them. They're all good. We appreciate them. We embrace them. We want to support them. But they're not going to get us there. I mean, as Tom was suggesting, and Jody, when you have people have an opportunity to leave for 30, 40% better salary and higher benefits because of how the payment structures look in other systems, there is just no way we could even look them in the face and ask them to stay, because they're going to get an extra $1,000 to supervise somebody. Or, I mean, it's so incommensurate, the scope of the challenge compared to the various solutions. Again, they're important. I think they're going to be necessary building blocks, but really the platform is on fire, and those are good garden hoses, but we need something more than that.
Yeah, so I think that where we're thinking is one. And again, this goes to Jeff's earlier panel. We need a fundamental restructuring of the whole financing system for community behavioral health. We know it can work. We see our good friends and partners at the federally qualified health centers. There's a sort of version of that being tested out around the country called Certified Community Behavioral Health Center model. We think we need that kind of big fundamental shift in the entire system that would allow us to have a stable financial basis from which to really be available to all our community members that need care. In the shorter run, we also think in terms of retaining staff and recruiting new staff, making sure there's robust and adequate tuition reimbursement, student loan repayment programs that are meaningful in the amount we're able to provide. So not token, but really meaningful reimbursement with a commitment to stay in the work. These models exist elsewhere. We know they can work.
Well, we'll look forward to continuing to explore this with you guys. Thank you. We're just about at time. Anything else that you'd like to share today? This is good. Okay.
I think so.
I will say we're going to continue the discussion on Fourfront Contributor's website, www.fourfrontcontributor.org. Thank you to Jody, Jeff, Tom, as well as all of our attendees that joined us and shared great questions and comments. We really appreciate it, and hope everybody has a great afternoon. Thanks.
Thanks, Annie. Thanks, everyone.
Take care.